Good, David.
Good?
Yeah.
All right, so we're going to talk about blood flow restriction today. I know that most of you guys are pretty familiar with it already, so I won't spend a lot of time on the basics, but there's some new research out there that I just wanted to present to you guys. It can be pretty useful for what we do in here, especially with our population of athletes. So this is what we're going to do. So we're going to go over the basics, how it works, mechanism, action, common uses, which I'm sure you're probably all familiar with already, a couple protocols that I found while I was researching, and then the new research and some takeaways that we can apply to our setting here. So the basics of BFR, in the grand scheme of thing, really just makes the environment for the muscle harsher. So it makes the muscle work harder at lower intensities, so we can get more out of 10-15% of a 1 rep max, as opposed to having to work at like 75 to 85% of a 1 rep max. BFR isn't really cutting off your arterial blood flow. You're really cutting off the venous return back to the heart. So you're not, those metabolites that the muscle's producing while it works aren't able to leave. So the muscle has to kind of work harder with less resources to accomplish the same job. And then at the bottom there, BFR has been shown to increase muscle thickness, strength, and endurance. Some common uses real quick. Obviously we use it multiple times a day here, especially with the new smart tool, whatever it's called. But tendinopathies, anything post-op is going to be really beneficial for it, because again, you can use really light load and then get a very positive response from that. And then obviously we can use it in some of our athletes too who aren't here just for rehab. We can use it for just regular strengthening as well, which we'll kind of get into more with the new research. These are some protocols that I found, pretty common protocols that I found going through the research. Strength and hypertrophy, 2 sessions a week. You want to work around, if you can, work around 20 to 40% of the 1 rep max. 2 to 4 sets seems to be enough volume. And then the pressure, which is how much the cuff is squeezing, you want to work anywhere from 40 to 80% of that arterial occlusion pressure. So with the cube here, I would assume that 40% is probably that low intensity, and 80% is that high intensity, and anywhere in between would be the medium intensity. In general, they want you to get to 75 reps in total, so the pretty common scheme for that is 30 reps, 15, 15, 15. I saw a couple other ones where the last set isn't to 15, it's just to mechanical failure, but that doesn't really apply to everybody, because not everybody has taken like a muscle to complete failure, so they might not know what that feels like. And then the rest periods are pretty commonly 30 to 60 seconds between sets. Isometrics is a little bit harder to prescribe, I guess, so we're going like 20% of the maximal voluntary contraction. So you'd have to know what the maximal voluntary contraction is, but for isometrics, you can really just have them work at their own intensity. 3 sets of 90 seconds, so that's a little different from like a tendon protocol where you would do like 5 sets of 30 seconds. Again, 30-second rest, and then it's more of a solid occlusion pressure, and then you just want to keep the occlusion going throughout the sets, so you don't want to let that go. For strength and hypertrophy, you can, depending on how much time, we don't really do it here, but you can like let the pressure off and then put it back on in between sets. And then something I found that was pretty cool was aerobic. I haven't really thought about using BFR for like endurance training, but I remember I think Nolan was talking about using it on the Echo bike. So you can use it for that too, and then you would just use heart rate reserve as your intensity modifier for that. And then commonly you would just use the bike, or you can do it walking too, so there might even be some benefit for introducing walking into like an early ACL rehab protocol. So the new research, this systematic review is kind of what I based this presentation around, because I thought it was pretty applicable to our setting here, looking at blood flow restriction and its effects on the rotator cuff in baseball players. So when we look at BFR, we usually look at using it for distal structures, distal to the cuff, but there's a lot of new research coming out where the rotator cuff is actually getting some benefits from it as well. So this study found, over multiple studies, they found that the common consensus was BFR applied to the rotator cuff has been shown to increase muscle strength, hypertrophy, and surgical outcomes. They did mention a study in there where the doctor looked at 2 different types of surgeries, rotator cuff repair and a rotator cuff debridement. The debridement showed more favorable results, but I think that's just because it's a less invasive, less intense surgery. Another big finding from this systematic review was low load BFR alone was beneficial, and then the high resistance training alone was beneficial. But if you increase them, or if you combine them together, you get the best results. So low load BFR with high resistance training. Obviously, this isn't something, if we're using BFR to get away from high resistance, you're not going to use that in like a rehab patient. But somebody who comes to mind is like Gene. You could do BFR with on a day, maybe if he's not feeling super hot, you can do BFR and then heavy resistance training afterwards. Third, they found that concentric BFR was greater than eccentric. So if you're going to find a place to focus, you might want to look more into concentric contractions as opposed to focusing super heavy on the eccentric. And then they did go on to say that further research is needed in specifically baseball players, but definitely is something that we can apply to our setting here. And then these were two other studies that the systematic review brought up. I can't really see them, but so they were looking again at the effects of BFR on rotator cuff. So I figured I'd put in the parameters here just so we know if we were to go and try this for a rotator cuff patient, we would know what to do. And again, the parameters here, they did 30, 15, 15 to failure 2 times a week. And it was shown to increase muscle mass, isometric strength, and work capacity. And then something that I kind of took from this was higher volumes are needed to have these effects. So there's a couple other studies. This top study looked at BFR on the rotator cuff, and they found no difference. But the study on the two studies on the bottom found a pretty significant difference, and the main difference was between the two studies was volume. So you really have to look at how much volume you're prescribing for somebody. In that top study, they only used one exercise 2 times a week for 8 weeks. And they did the traditional 30, 15, 15, 15 reps for 75 in total. And that didn't have any favorable results for the rotator cuff. But these 2 studies at the bottom, they did the 30, 15, 15 failure, 20%, 1 rep max, and they did, 4 different exercises there. And they found really good results from that. So when we're thinking about prescribing this to our patients, we need to think about how many exercises we're doing. The parameters seems like the last set to failure is going to be more beneficial than just 3 sets of 15. And you have to look at how many times a week and the overall volume of it. Because again, the BFR was intended for distal structures, so you have to kind of hammer home the volume for the proximal structures as well, I think. Yeah, so again, that's pretty much the takeaways for here is we got to look at volume, and we can also consider now that BFR is going to be beneficial for proximal musculature to the cuff, and we can use it in athletes as well. I think a really beneficial thing would be if somebody came in from throwing one day and they were pretty sore and they didn't really want to do a full workout or couldn't do the full workout, you can implement some BFR there and then still get some benefit from that. And then again, the biggest thing here would be looking at how much volume we're prescribing to somebody. If it's not enough, most of the time it won't be enough, so you have to kind of overemphasize that volume. Maximum 1-minute rest periods before sets. Probably better to do a shorter rest period if the patient can handle it. 30 seconds is usually the standard there. And then lastly, the biggest takeaway here would be BFR paired with high intensity resistance training with the appropriate population is going to be more beneficial than just BFR alone. So anytime you can implement both would be the best thing there. I think that's it. Yep.